Okay. I think we have our first question. So first I want to say thank you very much to spectacular presentations from all three of you. It's so great to have ESAS represented here so strongly. I also want to point out that Dr. Eisenach is on the call, and we are grateful to have his presence as president of FAIR. So we have our first question, which is to Dr. Tawfik. Well, our first question from Amanda Naylor, if you want to go ahead and ask your question.
Sure. Hi, my name is Amanda Naylor. I'm a second-year student at Loyola University Chicago Search School of Medicine. My question for Dr. Tawfik had to do with the PSTP programs or T32 programs. I had two questions about that. The first is, are those mainly for basic science research, or are there also clinical and translational opportunities? And then also, how does the application to those programs, what does that look like? Is that the standard residency application, or is there a separate process for that too?
Thanks, that's a great question. I actually have some slides on that. I'll just share them because I think my internet might be in and out, so it might be better just to have something visual as well. So hopefully you can see my slides here. So they're sort of two different things. So a PSTP, Physician Scientist Training Program, is something that really integrates research into residency. It's considered a short track program, and it usually comes with research time within the residency. These usually are applications for most programs that you're doing at the time you apply to residency. You also apply to that residency program's PSTP program. So for programs where there's actually a separate match for their PSTP, but the vast majority you match into the clinical residency and you announce your interest in the PSTP, and then you become part of that track. The T32, on the other hand, is an institutional grant that provides protected time after residency. And for many of these programs, the PSTP is sort of the feeder for the T32, where you would be in the PSTP program, and then when you graduate residency, the funding for your protected research time when you graduate would come from this institutional grant. But there are also a lot of spots on these T32 programs that you can go into outside of straight residency. So you could, let's say, do your residency at WashU with Mike Montana, and then decide you want to come do your T32 research with me at Stanford, and you could apply to our T32 directly as an outside anesthesiologist coming in. There are 16 anesthesiology departments in the US that have T32 funding. It's through NIGMS, which is the National Institute of General Medical Science. But there are many other programs that have research tracks. So there's certainly no limitation to only going to one of these 16 programs. There are many programs that offer research. And so that's something to think about. You either start it as a resident and sort of get the time during residency, or after your residency, you can go into a T32. Hopefully that makes sense.
Dr. Montana or Dr. Wagener, do you have anything you want to add to those thoughts?
Yeah, I'll say that I was on a T32 for part of my training, and it's a really nice opportunity if your division or department offers it to you. There are, like Dr. Tawfik said, there are many programs throughout the country that have T32s. And so if you're considering pursuing a research career in anesthesiology, just trying to ask about that and look into it is worth doing. It's pretty transparent. It's not hidden. You just have to ask.
Yeah, most people don't
Wagener?
have problems getting on. Hey, this is Dr. Wagener. Most people don't have too many problems getting onto the T32s. They're usually developmental grants that if you are a good specimen that they think that they can train, usually you can get onto those T32s, and they are very useful because they will get you protected time with a mentor to be able to do those things. I also agree with both my colleagues that I would advocate for the various programs that are inside the institutions, and UAB, Duke, Vanderbilt, Emory, places all over the country have those where they have protected time. during residency, and some of them even come with a stipend so that you would be able to get your research started there.
Fantastic. Okay, Thomas, you go ahead and ask your question, please.
Hi guys, thank you for sharing. My question was how different is it to have a MD PhD versus an MD for research purposes? Because I noticed that all three of you guys do have spent significant time doing research, and as someone who perhaps is wary of the length of time it takes to do a PhD in addition to an MD, does that affect future research opportunities, and if so, how?
This is Dr. Montana. I can start with that, feeling that question. I have a PhD. I don't think you need one in any way, shape, or form to do research. I think the main thing you need to do research is drive, ambition, luck, and a good question. So I would not encourage anyone to get a PhD just for the sake of getting a PhD. That said, a PhD is useful if you have a very specific kind of skill set that you're trying to learn, or a depth of understanding in a specific field you're trying to gain. And there are definitely ways for people to, who are not in MD PhD programs, to get their PhD or get a PhD either in their training program or afterwards. So I think the answer is no, you don't need to have one. The opportunities for MDs and PhDs and MD PhDs are different, but I think what you might want to consider is trying to figure out what your end goal is, and then go back and determine whether or not transitioning into getting a PhD is worth it or not. I hope that helps.
I'll second, this is Dr. Wagener, I'll second Dr. Montana's thought. A PhD is not absolutely necessary. The reason that I did it is when I was an undergrad, I was thinking about doing research, and people had told me, well, just get your MD and then you can do research. What I noticed is that my wife's lab that she worked in as a research tech before we went to medical school, there were a couple of ID fellows that were in there that were supposed to have protected time and do research. But what I noticed is that the cells and the mice or the data or whatever it is never actually gives you any thanks or any credit. But when you go and see a patient and you get them through their anesthesia, or you take out their gallbladder, or you give them the antibiotic that gets rid of their cough or whatever it is, the patient goes, gee, thanks, doc, right? So then you get motivated to actually sometimes be in the clinic rather than be in the lab, because the data, like I said, the data never thanks you. So I only did my PhD mainly because I wanted protected time where I had to do the work that would make me learn the scientific method, make me learn some broad skills and some specific skills that would enhance my research in the future. I think that those can be achieved because, as I said, research is, another skill, the same as intubating, putting in a central line, judging volume status, whatever. It's just one that takes time, and sometimes it's not a thankful process.
I'm just going to add something because maybe I have a slightly different view of it, which is, while I agree you don't necessarily need a PhD, I think the answer is really, it depends what you want to do, which is what Dr. Montana said, which is that if you want to do basic science and have a split between a career in clinical work and basic science, it's really challenging to do that if you haven't done the hardcore training of a PhD or at least several years of research. And the bottom line is that people who have a straight PhD are going to be spending 120% of their time on basic science. And those are the people you're competing against for NIH grants. And so to come in without any background in research and suddenly think that, you're going to be able to run a lab and get R01 funding without having ever trained as a PhD or done significant amounts of research, I think is a bit, unreasonable. I don't think that would happen. What we've done at Stanford is that those who come in with an interest in research, and I'm sorry, this gets back to Amanda's question, which I think I didn't fully answer, which is do you have to be doing basic science? And the answer is absolutely not. If you're passionate about research in any capacity, then we're thrilled. It's not necessarily about the exact question, but about the interest and the excitement about it. And so all that to say, what we've done at Stanford is that those who come in with an MD and no advanced degree, but are interested in clinical research, we have had them do a master's in science and epidemiology or master's in epi, because the feeling is that if you're going to be spending X percent of your time, call it 70, 80% of your time doing research in some capacity, that means you're going to be writing grants, that means you're going to be writing manuscripts. And the expectation is that you're going to be at the top of your field. And you really need to spend the time to get the additional training to really be at that level. And so while you may not need a PhD to do, an MSTP program, MD PhD, at some point there is going to be a necessity, if you want to make research a big part of your career, there is going to be a necessity to really invest time in the learning and the education to be the best clinical trialist, to be the best, epidemiologist or whatever area it is that you're interested in.
Fantastic. And I will say, as a person the only person without an MD, well, I guess maybe Dr. Eisenach too, it's possible to do research without a PhD, but you really have to commit some time to doing research. So it doesn't necessarily matter if you get the PhD, but doing the PhD gives you time to deeply delve into doing research, and that's the value of it, and that's, I think, a big value of the PhD is the time you commit. Sadia, I think, has a question.
Hi, everyone. My name is Sadia Tahir. I'm a second year at University of Toledo, and my question is, what are some things students can do in medical school to prepare themselves for a physician scientist training program? I know that research is an obvious component and we should partake in research that we're excited about and interested in, but I'm just wondering if there's anything else we should be aware of.
I can start feeling that question. I think you hit the nail on the head. First, if you want to do physician scientist training program, you need a background as a scientist. So the only way to do that is by doing some form of research. That's the most important thing, I would say. The other things that you can kind of start icing cakes and so on and so forth is look to see if there are training grants at your institution, or look to see if there are ways that you can get a track record with getting a little bit of funding, or you could take a year and do a master's in something, to really, or a PhD if that was the appropriate thing to do for your career. But the most important thing is, in order to do a physician scientist training program, you have to do research. So.
I would also add that you need to clinically excel. And part of that is if you do a PSTP type program, you're going to be out of the OR in the case of an anesthesiologist for up to 9 months during your 3 years of clinical training. And so you really do need to be an excellent physician in order for you to obtain the same level of excellence as your colleagues in a shorter amount of time. So I would say, when you're clinical, really focus on learning as much as you can. Like Dr. Wagener said, when you're there, soak it all in, take it all, learn from your faculty, from your interns and your residents, and really become an excellent clinician. Because if you're going to be out of the clinic for some amount of time, out of the OR, you do need to be able to catch up somewhat.
And I will agree. I will second and third their comments. If you're going to be involved in research, and do one of the PTSPs, because we do, like I said, we have one at UAB, and every applicant that comes in, when I talk to them during the interview, I tell them that their number one job is to be a good doctor. If they're not excelling at residency, they're a lot less likely to get that protected research time, because they're going to have to go back and do all of that work. Your job is to be a good doctor first, and then be an excellent researcher after that.
And I apologize, I have to jump off to get on a different phone call. I noticed that student Dr. Shen sent something here, so I'm going to jump in line. So for academic pediatric anesthesiology, Is it looked upon strongly to pursue an MD, PhD, or joint degree in addition to a program like WashU's ASAP? Sure, like an MD, MBA. No, not necessarily. There's nothing super special about letters after your name. It's more like what you've done and what publications you've got and how you've done your work and who you've worked with and your drive to succeed, both, as Dr. Wagener said, clinically and scientifically. So you certainly don't have to pursue a degree in order to, or an additional degree besides your MD to do that. You should choose to pursue those degrees if you think they'll benefit you.
I will note that we are at time. I'm going to give Christine an opportunity to ask any additional questions she needs. Dr. Wagener, if you have to go, that's fine. I think Dr. Montana and Dr. Tawfik may also have answers for that.
Please email me if you have questions. I'm happy to chat. So Christine, oh, go ahead.
Sorry, yeah, thank you very much. I don't want to keep you anymore, Dr. Montana. You answered the question as I was hoping in all of the, I guess, specificity I was hoping for. So I just want to ask Dr. Wagener or Dr. Tawfik if you have any experience with yourself or with your colleagues at Stanford. It seems like a lot of academic medical centers are working on developing ML AI algorithms to predict treatment and outcomes. So I'm just wondering, do you think this will be the main focus of applying ML and AI to anesthesia in the future, or is something else on the horizon? And how could we, if we're interested in something like this, how can we format our education to kind of pursue this?
Well, I guess since I'm the one who brought it up in critical care, I'll have to answer the question. So I think that this is a direction that people are moving with anesthesia and within critical care. Currently, it seems to be a matter of being able to predict outcomes. So now, if you look in the journal Anesthesiology or ANA or a variety of other anesthesia journals, you'll see a lot about this. And people are trying to, for example, predict based on the data that they're taking in from patients' vitals when hypotension will happen in the OR 15 minutes before it happens. There's some papers that suggest that they can do that. And of course, that would be important because hypotension in the OR, even if only for 3 minutes between blood pressure cuff checks, the longer it goes and the more severe it is, the more likely you're to get acute kidney injury and things afterwards. So people are definitely moving that direction. People are talking about it in the ICU as well, to be able to predict sepsis earlier, to engage treatment quicker, because we know that that leads to better outcomes. I will say that my department just recently hired, I think he would call himself a statistician, but somebody who focuses exactly on AI, and has solicited questions from us that we may be able to answer. So I think currently it's predictive, but they also want in the future, I think, to make it algorithmic and potentially therapeutic, right? So in the OR, if you knew you were about to get hypotension, the machine may decide that, or the machine may decide that the patient needs a bolus, you need to turn down the anesthetic gas a little bit, maybe not give a dose of fentanyl, whatever. But I think this is a big thing coming in the future. If you want to get into it, I think you probably need to find somebody who's expert in it. And my guess would be that some biostatistics training would be helpful with that. But I'm learning from others, so I don't know if I can exactly answer how to do it because I'm still figuring it out myself. I'll let my colleague answer as well.
So Doctors Montana and Tawfik both had other calls that they had to get to, so Dr. Wagener's the only one left on. I don't have any new questions here. We are beyond time, as always. So if anybody has a final question they want to ask, that's great. Just going to leave a little space for that. And if not, I think we'll wrap this up. And in their absence, I will thank Dr. Tawfik and Dr. Montana. And in his presence, I will thank Dr. Wagener for fantastic presentations. And I will thank all of you students for joining us.